Good afternoon, ladies and gentlemen. It's my pleasure to start the third session in this conference. Sponsored by the African Federation of Fertility Societies, AFFS. And it's my pleasure to present once more Professor Silke Dyer, Professor of Gynecology, Obstetrics, and Reproductive Medicine. She's the director of ANARA, which is the African Network and Registry for Assisted Reproductive Technology, and the Clinical Data Director of the International Committee for Monitoring Assisted Reproductive Technology, the ICMAT. The topic of Professor Dyer will be strategies to improve quality ART in Africa. Professor Dyer.
Thank you. I'm not sure we need that. To define what we mean by quality of care. The World Health Organization has defined quality of care as a degree to which an intervention, in our case ART, increases the likelihood of the desired outcome, in our case a baby, and is consistent with evidence-based professional knowledge. And this definition goes hand in hand with WHO's emphasis on the importance of national and global data that matter, and to use these data to improve health service delivery and outcome. And so it is from this angle, from this lens, that I want to address the subject matter of my presentation. Africa has started to collect national and regional data in a more consistent and cohesive manner, starting with the beginning of our African Network and Registry for ART in 2013, and so we are 8 years old now. As of 2020, and you can see here the growth of the registry in terms of countries, centers, and cycles, and I will be showing you the 2020 data in a moment. In 2020, we saw an 18% reduction in the number of procedures reported to the registry, and that is entirely expected and related to the COVID pandemic. And indeed, the 18% reduction is exactly the same reduction that we've seen in our neighboring region and registry, the Latin American registry. What is very pleasing that the 66 centers, including 10 centers from Egypt, have 74% of these centers are now reporting cycle-based data. And cycle-based data are far more granular and superior for analysis and robustness than retrospective summary data. But we do still have centers that are reporting retrospective summary data. They still need to adapt the capacity to develop, report cycle-based data through the software. And our mission or strategy is very much aligned with this. It is very simple: to measure, to share, and to help to improve. And to emphasize that sharing does never mean disclosing patient information or the information of any specific center. That is always confidential. And so in keeping with this strategy, I will first share with you some of what we have measured, and then explore how we can use the data to make impact. And also important to emphasize that the data that I'm sharing is representative for the community of practice that is part of the network. It cannot be extrapolated to all centers or to the whole of Africa. So the first variable that we look at, and which is so important because it influences success rate and outcomes, is the age of women. And here we can see over the last 6 years that Africa still has the youngest population when it comes to age in the global context. We do seem to see a trend towards older age in the last 2 years, and it will be important to monitor this trend. But this relatively young age profile is important to keep in mind when we interpret some of the successive data now. Before we can consider effectiveness, we need to consider the degree to which pregnancies are followed up to the point of delivery. And this graph illustrates, which shows you the proportion of clinical pregnancies that are resulting in a reported delivery, and it shows you the comparison of Africa in orange compared to the Latin American network and registry in gray. And what we are seeing that in Africa, 30% of pregnancies result in a reported delivery, comparing consistently to about 70% in Latin America. There's another very important difference. In Latin America, we know the outcome of the other 30%. They are well accounted for in terms of miscarriages, a few ectopic, and less than 10% of pregnancies lost to follow-up. Whereas in Africa, we don't really know what is happening to the other 70% of pregnancies. The low rate of pregnancy follow-up to the point of delivery forces us to use clinical pregnancy rate rather than delivery rates as a measure of effectiveness. Here I'm showing you the effectiveness clinical pregnancy rate per embryo transfer over the 8 years of ANARA, comparing fresh in gray and frozen cycle in yellow. And we can see that the effectiveness in fresh cycles is relatively constant and high, just under 40%. And we can see that the effectiveness in the frozen cycle is steadily increasing. And that is similar to other world regions, although Africa is lagging about 5 years behind these trends that we see when we compare ourselves to Latin America. But as of 2020, we see this equipoise in effectiveness between the fresh and frozen cycles. And this is all the data, cycle-based and retrospective summary data together. Importantly, too, despite a young population, we still practice relatively little frozen embryo transfers. The proportion of FET cycles over all transfers in Africa in 2019 was 30%, and that compares to 60% of the global average according to ICMAT in 2019. Now we go into the cycle-based data. As I said to you, they are much more granular and much more rich in terms of information. And here we can see that we already have a greater discrepancy between the clinical pregnancy rate in the frozen cycles versus the fresh cycles. I don't know if we can remove that red dot that is appearing there. I'm not using it. And the next graph shows us why we have that difference. Because in the frozen cycles, we have more blastocyst transfers compared to fresh, which has got about 50% of cleavage stage embryos. And then the last bar graph shows us that we're achieving this higher pregnancy rates with a lower multiple delivery rate because we are transferring fewer embryos, speak blastocysts, in the frozen cycles. Now this graph tells us what we all know, but it is still important to document it. And that is that the effectiveness, the clinical pregnancy rate in the transfer of blastocysts is higher compared to cleavage stage embryos. But even so, when we compare fresh and frozen blastocyst transfer, blastocysts in this real-world data have an age, the frozen blastocysts. And this is possibly because women are different who've got frozen blastocysts, and maybe also the receptivity of the endometrium. This is arguably the most important slide of my presentation. And it shows us that in Africa, I'm showing you here 6 years, but we can go back to 8 years, our multiple delivery rate remains high and is not really changing. It is over 25% with the exception of 2018 when it temporarily dipped. And we consistently are transferring more than 2 embryos. We thought the trend line was going down, but then in 2020 it went up again. In 2020, 47% of fresh autologous transfers involved 3 or more embryos. And you can see the multiple delivery rate was 27%. We do need to be concerned about this because, as I was showing in my earlier presentation, we show year after year for those pregnancies for which we know the outcome that the majority of twins and triplets are born preterm. 60% of twins following ART in Africa and 80% of triplets are born preterm. And their perinatal mortality is substantially higher compared to singletons. These data dynamics are not unique to Africa. We see absolutely the same trend in the Latin American data, but in Latin America, the multiple delivery rate is 16% compared to our 27%. Our data also tell us, and I've just heard this conversation, that it is not necessary to transfer so many embryos. So what we see here is that the elective transfer of a single embryo, usually a blastocyst, out of a surplus of more blastocysts which are good enough to be frozen, has a 36% clinical pregnancy rate with essentially zero risk of multiples. Yes, if we transfer 2 embryos, we will have an increase in the clinical pregnancy rate, but we are also jumping multiple deliveries to 27%. And then if we transfer 3 or 4 or 5 or 6 embryos, we will not further increase the clinical pregnancy rate, not according to the real-world data from Africa. So these embryos really should be frozen, because then they can contribute to the cumulative success rates. Whether Africa is ready to embrace more elective single embryo transfers is an interesting conversation, but time doesn't allow me to have this conversation here. Instead, I would like to make an interim summary. Our real-world data tell us some basic but important scientific truth. Blastocyst transfers is superior to cleavage stage embryo transfers. The outcome of the frozen embryo transfer cycles is equal or superior to fresh embryo transfers. I'm not making a plea for routine embryo freezing. We are dealing with different women. But I'm saying Africa can be more confident in adoption of frozen embryo transfers and cryopreservation. The transfer of 3 embryos, more than 3 embryos, is not effective. We are not increasing clinical pregnancies, and it's not efficient because we don't give them a chance to increase cumulative success rates. Multiple babies are born prematurely with a higher risk of mortality, and we have an insufficient outcome of ART pregnancies in Africa. And if we come back to the definition of the World Health Organization of what we mean by quality care, the desired outcome, which is a baby, we unfortunately have to say that our claim on quality care and effectiveness of ART is still a little bit on weak legs. I know that's not a popular statement. So now, what are we going to do to improve what we are doing? And I often quote the statement from my colleague and friend Ibrahim Wada in Nigeria, he's a speaker later in the session, that Africa still needs to embrace more the power of scientific data. And I say to you that the power has 2 siblings. One is responsibility. Power comes with responsibility. And the other one is opportunity. If we have power, we also have opportunity. So for the remainder of our talk, I will now look at how we can harness this power at the level of the centers, the country, our region, and our region in the global context of ART. The quality of ART in Africa is as good as the quality of ART delivered in each and individual center. Our centers are the DNA of ART in Africa. And so my question to every center is, do you know the answer to the questions that I've listed here? I'm not so much interested in the individual answer, but do you have the answer? And if you have the answer, are you acting on the answer, and are you using the information to compare yourself to national, regional, and possibly international benchmarks? And do you have a data officer? And if you have all of that information and you're not yet sharing it with the registry, I invite you to do so. And if there are any concerns about the confidentiality of the data and the protection of your data, I invite you to speak to me or for Egypt, Prof. Iman. Harnessing the power of our registry data at the level of the country means that we need to share the data, again, without ever sharing the data of individual centers or patients. But there is a wide range recognized of data consumers of registry data, and I've listed them here. They're all important, but I want to focus on the funders for a moment. Because the study that I'm showing you on the right-hand side again tells us something that we know, and again it is important to document, and WHO has documented it. And I was privileged to be part of the study. And it shows that the cost that patients pay out of pocket for one ART cycle exceeds the average annual income per capita in most of these countries, and in many countries it exceeds it by far. So ART in low and middle income countries for the majority of people is not affordable unless we can get funding. And I'm excited to share a story of success from South Africa, where the funders, the medical insurances, became aware and interested in the South African national data, which forms part of ANARA. And now that we have data on safety, effectiveness, and efficiencies, the funders are beginning to fund ART. But they did want to see an accreditation system. So our fertility society started voluntarily accrediting AAT centers, and part of the accreditation is reporting to the registry. So the registry helped to bring funders to the conversation, and now the accreditation process is strengthening the registry, and we have more representative data to monitor what we are doing. So it really is a win-win situation, and the people who win the most are our patients. At regional level, and particularly with regards to our network and registry, we do still need to strengthen the registry data. We need to invite more centers to participate and more centers to report cycle-based data. And to help the centers to do so, we have developed the INARA data courses. We have an entry-level course and an advanced-level course. And yes, it is about building skills and capabilities, but it is also about helping the data, those who are responsible for data, the biologists, the fertility nurses, the data managers, to engage and to enjoy interaction with scientific registry data. So it's not so much only about how, but why. And I'm happy to say we now have over 30 certified data managers at level 1 or level 2 in Africa. Another exciting project is that in conjunction with our sibling registry, the Latin American registry, we are now developing health education material for patients. Very simple, very clear, and I'm happy to share that with you. So to bring the registry data back to patients and to support their reproductive autonomy and their health literacy. How does Africa fit into the global picture of ART? I'm good with time. In 2023, ICMAR collected the world data for 2019. Registry data always lag a little bit behind. 81 countries reported 3.4 million ART procedures. All of Africa together, 18 countries, represented 1.4% of the world data. So we are not yet representative of our continent, which would be 11%. And we are not yet meeting the demand of ART in our own region. We have work to do. And we can only do this work together. And the experience of INARA over the last 8 years, and the experience of Latin America over 30 years, is showing that centers, that we can collaborate despite the fact that centers are competing with each other. And so this collaboration, this network with the registry as a strong backbone, which is inclusive of competition, is really the foundation of strong regional development towards quality ART. And registry data is not about the good or the bad or the right or the wrong. As my friend from the Latin American registry, Prof. Fernandez Iga always says, registry data are like the needle of a compass. They draw our attention to where we need to pay attention, they tell us where we are, and they help us to decide where to go. And with this, as always, I acknowledge and I'm deeply grateful to each and every center that is participating in the registry, to each and every individual, directly and indirectly, that is helping to support and enable the vision and mission of INARA. I thank you.
Thank you, Professor Dyer. It's really a pride for the work that you're doing and Dr. Iman is doing on Egyptian side.